What's up, everybody? Today we will practice challenging questions that will sharpen your test-taking skills. We'll tackle standalone scenarios, break down the answers with rationals using pro test-taking tips to help you stay calm and focus on the exam day. So jump in, take some notes, and ace these questions. And if you love this content, be sure to like and subscribe to this video for more NCLEX preparation tips.
Before moving ahead, I have some exciting news for you. If you are determined to pass the NCLEX within a week or a month, then your best option is to enroll in our complete online NCLEX review crash course right now. This course is a comprehensive all-in-one solution, a guaranteed shortcut, and a proven method to pass. Over the last 5 years, more than 5,000 students have successfully cleared their NCLEX exams using this course with an impressive 99% passing rate. Here's what you'll get: 100-hour animated mini crash course, ideal for those who have limited time and want to pass in just 1 week. 300-hour comprehensive recorded lectures covering 300 high-yield NCLEX topics that the exam loves to test. 5,000 real NCLEX questions, practice with actual past exam questions for better preparation. 15 full-length practice tests, including CAT simulation. Feel confident before your real exam day. Exclusive NCLEX ebook, the ultimate guide you need to pass. 1 year full access. Study anytime, anywhere, at your own pace. This is a limited time offer. Enroll now to grab 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. All right, now let's dive into the topic.
So the first scenario that we have is a bow tie, and here it goes. It says, a nurse is attending to a 78-year-old patient at the primary care physician's office. The nurse's note says at 11:15 a.m., the patient was brought in by relatives due to concerns about worsening memory issues, impaired decision-making, and irritability. The patient has also begun struggling with dressing appropriately, such as attempting to wear panties over her pants this morning. The patient has a history of high blood pressure and elevated cholesterol, both managed with medication and dietary changes. The patient can eat and bathe independently, resides with family members who oversee medication management. The patient is alert and oriented ×2, height 5 feet and 4 inches, weight is 165 pounds, vital signs, temperature 98.4 degrees Fahrenheit, heart rate of 84 beats per minute, respiratory rate 18 breaths per minute, blood pressure 130/65, oxygen saturation at 95% on room air. So your task is to fill in the diagram by choosing from the options provided to identify the potential condition the patient is experiencing, 2 suitable nursing interventions, and 2 parameters to monitor. So here are the options for potential problem. One is major depressive disorder, Alzheimer's disease, delirium, dissociative disorder. And so for the potential problem, the answer is Alzheimer's disease, because this is a progressive neurodegenerative disorder, and this is characterized by memory loss. There's impaired judgment, mood changes, there's also irritability, and difficulty with activities of daily living can also happen here, such as in this case, the client is dressing inappropriately. And the patient's gradual onset of symptoms, especially around this age, 78, and the chronic history align with the Alzheimer's as the most likely condition. And in the NCLEX, it prioritizes recognizing those dementia patterns, especially with Alzheimer's in older adults with cognitive decline. Now, what about major depressive disorder? Why is this incorrect? Well, remember that depression can cause memory issues, also irritability, but it usually involves sadness. There's lack of interest or movement changes, mobility changes, I should say, but not specific daily activity problems like dressing mistakes. And since those typical signs are missing here, depression seems less likely in this case. Now, but what about delirium? This is also incorrect because delirium is an acute, it is reversible confusional state, and this is something that is triggered by infection, drugs, or metabolic issues. And this one doesn't fit because the patient's symptoms in this scenario are chronic and they're also progressive. They're not sudden. And the vital signs that we are seeing in the case are stable. There is no fever, no hypoxia, and this rules out delirium. And so in the NCLEX, you'll also be tested if you're able to differentiate between acute delirium versus chronic dementia or cognitive changes. Now, the last option is dissociative disorder. Why is this incorrect? Well, it is not correct because this one comes from trauma and this affects identity or memory. It is not a slow decline in thinking or daily tasks. And in this case, the patient's symptoms seem brain related, not mental health related. So it doesn't fit here. Now let's move into the nursing intervention. So carefully select those two nursing actions. And one of the correct answers here is explain the condition progression to the family. Why is this correct? This is a big deal because when you're teaching the family about how Alzheimer's disease gets worse, let's say memory loss and safety concern, this can help the family prepare for care and also set realistic goals. And when you are educating patients and also their families, this is also a big deal, as this is one of your roles, especially for long-term conditions like this one. And this is something that is usually tested in the NCLEX. Now, the other nursing action that you should be doing is to assess mental status using an evidence-based tool. And this is something that you should prioritize, which is basically assessment, right? And the reason for this is to establish a baseline and also to confirm the extent, the severity of the cognitive impairment. And this is something that you can do by using standardized screening tools such as the MMSE, we call that as the Mini Mental State Examination, or the MoCA, which is the Montreal Cognitive Assessment. And these are very important assessment tools that will evaluate dementia. Also, this aligns with the nursing process of assessment. Now, what about the other options, such as advising family about memory care options? Why is this incorrect? Well, this is not suitable, although memory care might be an option down the road, but currently the patient lives with the family at the moment, and they will handle those basic tasks, like maybe helping the client to do their ADLs, and also wandering, which is not yet a big deal or a concern around this time. And suggesting this now is actually too soon without evaluating or assessing the client's worsening symptoms. So you're going to have to discard this one. Now, what about the referral or refer patient for cognitive behavioral therapy? Why is this incorrect? Well, the reason for that is because this is something that is used for mood or behavioral disorders. It's not intended for Alzheimer's disease, which is a neurodegenerative condition which is unresponsive to the cognitive behavioral therapy. And so if you are selecting this option, it's a misunderstanding of the disease process. And yeah, you should correct that. Now, what about the last one? It says, tell the family a drug may slow cognitive decline. Well, remember that our role as nurses is to explain medications after they are prescribed. We are not supposed to suggest the medication independently. And so you should follow the NCLEX scope of practice guidelines. And when you are informing the family that a drug might slow down cognitive decline, Well, this is something that you should do first. You should clarify the medications like cholinesterase inhibitors only when a doctor has prescribed them, not when you are suggesting. Now, what about parameters to monitor? What are those two? Well, one of the correct answers here is the bladder or bowel control issues. This is correct because losing control of the bowel or bladder happens later in the Alzheimer's stages, and this client is actually heading that way. And also, this can happen when there is worsening in their cognition, because this can impact their awareness of bodily functions. And so, keeping track of this will let the family prepare for care and also can support hygiene and support the client's dignity. And this also matches the NCLEX emphasis on safety and monitoring disease progression. Now, the other parameter to use here will be tendencies to wonder. Why? This is common and also a dangerous behavior in Alzheimer's, especially as the disease advances. And this is a major safety risk because the client can get lost. And of course, the NCLEX emphasizes safe related monitoring, especially in dementia care. Now, what about the other options, such as daily living skills? This is incorrect because the patient's current level of ADLs is already evident, so it's less critical than future risks like wandering or bowel or bladder incontinence, which the NCLEX prioritizes because of the disease-specific complications. Now, memory difficulties is also incorrect because memory impairment is already documented and expected in Alzheimer's. And monitoring this is redundant at this point. And in the NCLEX, it expects you to focus on emerging or safety-related parameters instead of restating known symptoms. What about judgment capacity? Why is this incorrect? Well, we already noted that there is impaired decision-making, right? There is dressing error, and it's an early sign that is already identified. And so monitoring should shift to potential consequences, such as wandering, rather than the underlying deficit that we are already noticing, per the NCLEX emphasis on proactive care planning. So that is something that you should keep in mind. So for this test item, I want you to make sure that you do your assessment first, especially with this patient that has been brought into the primary care physician's office. Before you do your intervention, especially since this is the first known encounter with an elderly client with worsening symptoms of Alzheimer's. And remember that this disease involves progressive memory loss. There is ADL decline, and there are also later risks like wandering. There is incontinence. And also, you need to distinguish this from the other problems such as delirium, acute delirium, or depression. And part of the care that we should be doing, especially in this patient, is to educate and monitoring, which is in our scope of practice. And the other options, especially for the nursing actions such as medication initiation or facility placement, these are actions that require further assessment and also prescription. So you should not be selecting these two. And then again, don't forget about prioritizing the client safety, because this client will progress into wandering in the near future. Let's have our next item. So this is a case of a nurse attending to a 28-year-old patient at an urgent psychiatric facility. This is a matrix multiple response. And according to the nurse's notes at 9:40 in the morning, it says family members brought the patient to the psychiatric facility alarmed by worsening hallucinations, disorganized speech and thinking, and poor impulse control. They note the patient sees things that aren't there and hears voices. After completing a 4-month rehab stint for meth use last year, the patient has consistently tested clean for drugs. Residing in the family's basement, the patient cannot sustain employment or personal connections. 3 years ago, the patient was incarcerated for 5 months due to inmate partner violence. Currently alert, yet confused and disoriented, the patient shows scattered thoughts, word salad, speech, and difficulty tracking conversations. Your task here is, for each patient observation listed below, decide if it aligns with schizophrenia or borderline personality disorder. Each observation may relate to more than one condition. So you have the patient observations, which are struggles with keeping stable relationships, visual and auditory hallucinations, and chaotic thought patterns in speech, and lastly, lack of impulse control. So your role here is to assign these observations if they belong to either borderline personality or schizophrenia, or maybe both. So let's tackle the first observation here. What do you think would be suitable for this one? Well, this one is something that can happen in both problems. All right, can happen in borderline personality disorder and schizophrenia. Why? Because in borderline personality disorder, this is characterized by intense. There's also unstable interpersonal relationships due to fear of abandonment. There is emotional volatility and identity disturbances. And in the case, the patient's inability to maintain jobs or relationships aligns with this pattern as borderline personality disorder, which leads to conflict-driven relational breakdowns. And in the NCLEX, this is really going to test your recognition of the BPD's hallmark of relational instability. Now, for schizophrenia, this is also true. It's because with schizophrenia, it can impair relationships due to social withdrawal. There is disorganized behavior or psychotic symptoms, maybe hallucinations, that will hinder communication and trust. And the patient's basement living and job struggles suggest that there is social dysfunction, which is common in schizophrenia. Now, what about the second one? This is something that you will see in schizophrenia. Why? Because with the schizophrenia, there is going to be hallucinations. They're going to hear voices, sees things that aren't there. And these are positive symptoms of schizophrenia, which is a psychotic disorder, which involves distorted perceptions of reality. Also, the patient's drug-free status rules out substance-induced psychosis, and the chronicity suggests that the client has schizophrenia. Now, why is borderline personality disorder incorrect here? The reason for that is because with the BPD does not typically involve true hallucinations. Even though with severe stress in BPD, this may cause transient dissociation or perceptual distortions, but these are not present or persistent auditory hallucinations like that you're seeing in a person with schizophrenia. So you got to be careful here, because in the NCLEX, you will be tested in your ability to differentiate between psychotic or schizophrenia versus personality disorders, borderline personality disorder, I should say. And so again, you have to point out about the hallucinations that is more common in schizophrenia. Now, let's have the third observation. Why do you think that this is going to be seen in schizophrenia? The reason for that's because in schizophrenia, there is going to be disorganized thinking and speech. There is word salad, flight of ideas, and these are classic positive symptoms of this disorder. And this reflects a break from their logical thought process. And in the case where it says that the client is unable to follow conversations, and some word salad, scattered thoughts. These strongly support schizophrenia. Now, why is it not borderline personality disorder? The reason being is that with BPD, it involves emotional dysregulation and impulsivity, not formal thought disorders like word salad. And the speech in BPD may be intense or could be erratic due to the mood swings, but it can remain coherent, unlike schizophrenia's disorganized patterns. Lastly, we have lack of impulse control. What do you think about this one? Well, this is something that you will see in both disorders. So that's going to be found in BPD and schizophrenia. Now, let's tackle first why it's true for BPD. Well, for BPD, this is true because impulsivity is the core manifestation or feature in the borderline personality disorder. Again, that is lack of impulse control, especially that they have a history of substance use. There's also aggression. And the client's history says that there is intimate partner violence, and there's also past use of meth. So these manifestations align with the borderline personality disorder's impulsive tendencies. Now, what about schizophrenia? Why is this correct? Well, the reason for that is because there is also poor impulse control in schizophrenia, especially during acute psychosis. And this is caused by impaired judgment or probably response to the hallucinations. They are acting out on those voices that they are hearing. And so the patient's worsening impulse control amid the psychosis supports this one as well. And so the main key takeaways for this test item is that you should focus on the hallucinations if you're going to see cases such as schizophrenia. They are characterized by hallucinations. There is disorganized speech, disorganized thinking, and there is also social dysfunction. And you've got to look for those positive symptoms such as hallucinations and negative symptoms. And this is the social withdrawal in the case scenario. Now, you have to make sure that you can spot these clues really fast. Now, if a patient hears voices or they talk gibberish, this is leaning towards schizophrenia. And with social dysfunction, if they're going to fail into some relationships or maybe some work-related issues, this is also going to seal the deal, especially if it's tied to psychosis, not just about being moody. And as nurses, it is our role to assess these to keep patients safe, especially if they're having hallucinations, because this might make them act out. And also with a withdrawal, it means that they're not coping well. Now, for the BPD, you got to remember that this disorder centers on the emotional instability. There is also impulsivity and stormy relationships. And psychosis is absent unless there is dissociative under extreme stress. So that's the main caveat here.
Before moving ahead, here's something you need to hear if you're feeling anxious about passing the NCLEX, especially if you're aiming to do it in 1 week or 1 month, then our complete online NCLEX review crash course is your answer. This is your shortcut to success, a tried and tested course with a 99% passing rate. More than 5,000 students have achieved their NCLEX goals using this course, and now it's your turn. Here's what's included. 100-hour animated mini crash course, perfect for last-minute preparation to pass in just 1 week. 300-hour comprehensive lectures covering 300 high-yield topics that the NCLEX loves to test. 5,000 real NCLEX questions. Train with real exam-style questions and be prepared for anything. 15 full-length practice tests, including CAT simulation. Build your confidence with realistic exam experiences. Exclusive NCLEX ebook and 1-year access. Study whenever you need without restrictions. Don't let this opportunity slip away. Enroll now at 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's jump into the topic.
Let's move on to a next item here. This is a drag and drop analyzing cues type of item. And so we have a case which says a nurse is attending to a 14-year-old patient brought by parents to the urgent care facility. According to the nurse's notes, at 10:10 in the morning, the patient mentions feeling increasingly short of breath, along with tiredness, weakness, and a chest pain episode during yesterday's school exercise class. The child is alert and oriented to person, place, time, and situation, appearing calm and at ease. Heart rate and rhythm are regular with a systolic murmur detected. The patient looks pale, has scattered petechiae, and shows slow cap refill. No pain is currently reported. Bowel sounds are present in all 4 quadrants, and bowel habits are normal. Menstruation began yesterday and muscle strength is full, 5 out of 5 in all limbs. Vital signs: temperature 98.6 degrees Fahrenheit, heart rate of 110 beats per minute, respiratory rate 20 breaths per minute, blood pressure 120/65, oxygen saturation 94% on room air, and we got measurements: weight of 140 pounds, height of 5 feet and 4 inches. Your task is to fill in the blanks in the sentence below by choosing from the provided options. So, the statement says the nurse must promptly address the patient's findings of blank, 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 and blank. So, we have the following options for blank one. We have oxygen saturation 94% room air, the delayed capillary refill. We have a BMI of 24. So among these 3 options, what do you think would be the most suitable option here? Well, for this blank, the answer is going to be delayed capillary refill. It simply means that it takes longer than 2 seconds for color to return after you press on the skin or the nail bed. And this is a direct sign of poor perfusion. Now, in this 14-year-old patient, it is a red flag because it suggests that blood is not circulating effectively, which could be due to low hemoglobin, anemia, right? Or it could be dehydration, or maybe a cardiac issue like the systolic murmur hinting at a heart problem. Now, when this is combined with pallor, there's shortness of breath, and an oxygen saturation of 94, this points to a circulation issue that needs immediate attention. Now, for pediatric patients, poor perfusion is an early warning sign of potential decompensation, and the NCLEX prioritizes these objective hands-on findings because these align with the ABCs. And the nurse might respond assessing further for, let's say, checking the client's anemia with laboratory, or maybe improving circulation. Could be using fluids or maybe administration of oxygen. Now let's look for the next answer for the next blank here. And the options are pallor, chest pain episode, blood pressure of 120/65. Well, before we go to do that, why are the other options incorrect, such as the BMI of 24? Why is this incorrect? Well, a BMI of 24, which is basically within the normal range for a 14-year-old, likely they're in the 75th or 85th percentile, depending on their sex. It is also a static measure of the body size. It is not an acute issue. And usually in the NCLEX, it will give you distractors like BMI to test whether you'll focus on irrelevant data instead of urgent clinical signs. Again, this is a static information, not an acute urgent data. So this isn't something that is going on to cause immediate concern to this patient. So get rid of the BMI. Now, what about the saturation of 94% room air? Well, a 94% room air is below the target range of 95 to 100%, but it is not critically low, which we should consider maybe less than 90%. And this is something that's not quite alarming yet. Even though it is a concern and it supports the overall picture of poor oxygenation, but the delayed cap refill is much more of an immediate objective sign of perfusion trouble. Now, what about the second blank? The answer for the second blank is supposedly pallor, right? Pallor, which is basically pale skin, a visible sign of reduced blood flow or oxygenation. And this is linked to anemia. There's hypoxia or poor cardiac output. And in this teen, the pallor also aligns with the delayed cap refill, the shortness of breath, and the oxygen saturation of 94, which reflect compromised oxygen delivery because of possible hemoglobin that is low, or could be a cardiac issue. And this is something that is also going to call for immediate action. This is a very observable finding that doesn't require any tests to confirm. So you should make this as a priority assessment finding. So you might respond to this by administering oxygen or maybe checking the client's hemoglobin levels after, and also notifying the healthcare provider. Now, what about the other options, such as the chest pain episode? Well, I want you to go back into the nurse's notes and check on that one. And it stated that the chest pain occurred yesterday during the exercise. So this is something that is not being experienced by the patient. We know that history is concerning, especially that they have a systolic murmur, which could indicate a cardiac condition like a valve issue. But then again, this is not an active problem at the moment. And remember that with NCLEX, it focuses on current urgent findings rather than past symptoms unless they are recurring. So this is a clue that will further require for investigation, maybe having an ECG to check on the cardiac rhythm. But then again, it is not an immediate priority. Now, the blood pressure of 120/65 is also incorrect because this is a normal finding for this patient. And sometimes in the NCLEX, it will throw you so many objective values that could serve as distractors to test whether you'll focus on the stable findings instead of the abnormal findings. Now, what about the next blank? The correct answer here is exertional dyspnea. All right. The exertional dyspnea is basically the shortness of breath that worsens with activity. It is a significant finding in this patient. Now, go back into the case scenario or the nurse's notes. It states the patient mentions feeling increasingly short of breath along with tiredness, weakness, and a chest pain episode. Now, the chest pain, again, is something that had happened yesterday. But for the meantime, the client is reporting shortness of breath, especially with activity. So a child at this age, they should not feel increasingly short of breath during routine activities unless there is something wrong, maybe a cardiac issue. They have a history of murmur, right? There is a structural heart problem, maybe a pulmonary issue or anemia. And with an oxygen saturation of 94% and pallor, this points to an oxygenation problem that needs immediate attention. And then again, in the NCLEX, it will test your ability to prioritize ABCs, right? Now, why is generalized fatigue incorrect? Well, remember that with the generalized fatigue or tiredness, this is a vague, it is subjective complaint that could stem from many causes. Could be from lack of sleep, anemia, or even emotional stress. Even though it's worth noting, it's not as specific or urgent as the exertional dyspnea, which directly indicates a problem with oxygenation or maybe cardiac function. Now, why is respirations 20 breaths per minute incorrect? Well, this is considered normal, right? For a 14-year-old at rest, they should have 12 to 20 breaths per minute. And the issue isn't about the rate. It is about the patient's subjective report of shortness of breath, especially with exertion. And we have the fourth blank rather. And so the last correct answer will be the heart rate of 110. This is elevated already, even at rest. Remember that their usual range will be 60 to 100 beats per minute. This is already tachycardia. And when it's combined with shortness of breath and if there is pallor or delayed cap refill, this suggests the heart is compensating for an underlying problem, possibly from hypoxia. There is anemia. And whenever you're going to encounter this type of manifestations, especially with peds, children, tachycardia is an early sign of distress, and this often appears before blood pressure drops in conditions like hypovolemia or even shock. And this can also align with the ABCs, making this as a priority. And so you as a nurse in this case might respond by monitoring the client's heart rhythm with the use of an ECG, or maybe administering oxygen, or maybe checking the client for dehydration. Now, why is systolic murmur incorrect? We know that this is important finding as well, because it might indicate a structural heart issue, maybe mitral valve prolapse or aortic stenosis. But this is a chronic that is a stable finding, not an acute change that's worsening right now. And the heart rate of 110 beats per minute, on the other hand, is an active sign of distress that needs immediate attention. Now we have the last option, which is weakness. This is similar to fatigue. This is a subjective complaint that lacks specificity, anemia or poor perfusion, but it's not as actionable as a heart rate of 110, which is an objective measurable sign of distress. So I want you to carefully strategize in answering this question. You gotta focus on the ABCs. You have to pick the objective, those urgent findings over vague or normal ones. And you gotta ignore those distractors like normal vitals, like the blood pressure, the respiratory rate, or the irrelevant statistical data such as the BMI. And something that you should focus on are those urgent, pressing issues that could relate to the ABCs 4 months prior. The nurse assesses the child's progress by evaluating how well the child and their parent are managing the condition. It says, for each body system listed below, identify the findings that suggest successful management of celiac disease. Multiple findings may apply to each system. So we have body systems, lower gastrointestinal, upper gastrointestinal, cardiovascular, and neurologic. Now let's find out about the client findings in the lower gastrointestinal system. What do you think are the answers here? Well, when the client's stool appears normal and lacking oily residue, this is correct, because with celiac disease, this can actually cause steatorrhea. There is going to be fatty, oily stools due to the malabsorption of fats from gluten-induced intestinal damage. And so if the stool appears normal without oily residue, this reflects that the child is compliant to a gluten-free diet. So this is going to allow the intestines to heal and also to absorb the nutrients properly. So this is a strong sign of successful management. However, if it says mentions hard and loose stools, this is incorrect, because when you see alternating hard and loose stools, this basically suggests that there is an ongoing gastrointestinal irregularity, which could indicate that there is incomplete adherence to a gluten-free diet, or there is lingering inflammation in the intestine. Although this is not as severe as a steatorrhea, but this finding does not clearly demonstrate successful management and may also reflect persistent issues, and that's why we're not picking on this one. Now, for the upper gastrointestinal system, the correct answer should be no instances of throwing up were reported, because vomiting can happen in poorly controlled celiac disease due to the inflammation or irritation of the upper GI tract from gluten exposure. And the absence of vomiting suggests that the child is avoiding gluten, reducing irritation, and also managing the condition effectively. Whereas if it says notes occasional bloating, well, when there is bloating, it indicates that there's possible gas buildup or inflammation. And again, this is linked to gluten ingestion or incomplete dietary control in celiac disease. Now, for cardiovascular system, the answer would be hemoglobin of 12 grams per deciliter, because this is within the normal range for a 10-year-old. And typically their levels would be 11.5 to 15.5 grams per deciliter. And this is something that indicates proper nutrient absorption and also successful dietary management. However, if the condition is poorly managed, celiac disease can lead to low hemoglobin levels due to the malabsorption of iron, could be malabsorption of vitamin B12 or folate when the condition is not carefully managed. Now, what about the heart rhythm is consistent and steady? This is incorrect because this is a normal finding, but it is not specifically tied to celiac disease management. Although, with a severe malabsorption, this could indirectly affect cardiovascular health through maybe electrolyte imbalances, but this finding is too general and not a direct indicator of successful disease control. Again, we are looking for those direct indicator that the client's celiac disease has been managed well. Now, what about neurologic system? What do you think would be the answer here? Well, the answer describes feeling livelier and more spirited, because fatigue and low energy are common in an unmanaged celiac disease due to nutrient deficiencies, could be deficiencies in iron or the B vitamins. But with increased liveliness and energy, this basically suggests that the child is absorbing nutrients effectively, which is a good sign of dietary adherence and disease management. Now, if you selected behaves in a friendly and agreeable manner, this is incorrect, because this reflects the child's personality or emotional state rather than direct physiological outcomes of celiac disease management. Even though improved health might indirectly enhance the mood, but this finding is not a specific indicator of a successful control of their condition. So for you to answer this question effectively, you got to understand the question's focus. You need to carefully identify what the question is asking. It is about findings that suggest successful management of celiac disease. So what you're going to focus here are those positive outcomes that are tied to the condition rather than general health indicators. And so you need to look for those findings that show improvement or resolution of celiac specific symptoms, such as no oily residue in the stools, normal hemoglobin rather than those unrelated or maybe neutral observations, such as heart rhythm that is regular and steady. And don't forget to apply your knowledge about the pathophysiology of the celiac disease and the management. So the management usually focus on the adherence to a gluten-free diet, which should be able to reverse the malabsorption, reverse the inflammation, and also the other related symptoms. And don't forget that celiac disease affects nutrient absorption. It will impact the energy. It will impact the hemoglobin level, and also the consistency of the stools and the vomiting. And you got to make sure that you're differentiating between systems. So you got to treat each body system as a separate mini question here, because this is like a grouping type of test. And you got to do this independently based on how the celiac disease affect that system. So for the lower gastrointestinal system, your focus here is on the stool quality, right? So if there is normal stool, that simply means that there is good management. If there is irregular stools, there is poor control. Now for the neurologic system, you're going to prioritize energy levels, such as liveliness. Because with that, if there is nutrient absorption, this is going to really improve the client's activity levels. And you got to look for the specificity, because when you are going to be tested with this kind of item, you have to choose findings that are specific indicators of the celiac disease control rather than vague or general health markers. And you got to eliminate those red flags for poor management, and you got to watch out for the distractor as well. Let's have our number 5 item. This is a highlight type of test. It says a nurse is attending to a 32-year-old woman who arrives at the labor and delivery triage unit in the early morning hours. So your task is to highlight the client's findings that require urgent attention and follow-up. So let's read through the history and physical. It says admission time at 17:30. The client states she has been experiencing uterine contractions occurring every 4 to 5 minutes consistently over the past hour. A current condition, gravida G2P1001, second pregnancy, 1 prior full-term birth. Estimated gestational age is 39 weeks and 2 days. Allergies, known sensitivity to amoxicillin. Physical assessment, vital signs, temperature of 98.8 degrees Fahrenheit, heart rate of 104 beats per minute, respirations 18, blood pressure 145/90, pain report 7 out of 10, mental status fully alert and oriented ×3, normal S1 and S2 heart sounds for cardiac, lungs clear on auscultation bilaterally, abdomen visibly rounded, consistent with advanced pregnancy, skin is dry to the touch, intact with no lesions or rashes, extremities moderate to plus swelling in both lower legs and feet, reproductive active fetal movements detected, cervical exam 5 centimeters dilated, 90% effaced, -2 station, obstetric history, pregnancy 1. The delivery occurred 2 years ago at 38 weeks and 6 days gestation. Neonate, male born, weighing 8 pounds 7 ounces. Outcome, healthy live birth via spontaneous vaginal delivery. Complications pre-eclampsia, anesthesia epidural administered. Non-reported for neonatal complications. Social history, primary language is Vietnamese. Support system, spouse is currently working overseas, younger sister taking care of the child in the waiting area. Now, what are the things that you should highlight here? So one of those would be the heart rate of 104 beats per minute. This is way above the normal range for a resting adult, supposedly 60 to 100. Although pregnancy and active labor can naturally increase the heart rate due to increased cardiac output, up to about 30 to 50% higher, especially in pregnancy, and the physical stress of contractions. But the 104 beats per minute is still on the higher side, especially when it is paired with other concerning findings. So in this case, the patient has a blood pressure of 145/90 and a history of preeclampsia, which raises the suspicion for a hypertensive disorder in this pregnancy. And the elevated heart rate could indicate that this is actually a compensation for the labor stress. Could be pain related, 7 out of 10, or maybe anxiety because she is alone with her spouse being deployed. And this could be related to a pathological cause. It might be an early sign of a hypertensive crisis, or maybe a pre-eclampsia worsening because the heart works harder to manage the increased vascular resistance or the shifting of the bodily fluids. And also, pre-eclampsia can lead to a decreased cardiac output over time if this is not treated timely. Now, remember that with pre-eclampsia, this can impact the fetus. The maternal tachycardia itself can reduce oxygenation perfusion to the placenta, and this is going to cause distress. And again, this can affect the fetal oxygenation. This is not really an emergency on its own, but the heart rate could be a sign that the client is developing preeclampsia at this time. And so you don't neglect this manifestation. So you should trend the heart rate, assess for the dehydration if there is, which is common in labor, especially if she's been laboring at home for hours, and you got to ensure that the fetal heart tones are also reassuring. And so if the heart rate continues to rise, or if there are any other manifestations such as headaches or visual changes that can appear, it could signal that there is worsening condition like preeclampsia or maybe maternal exhaustion. Now, the other manifestation that you should highlight here is the blood pressure of 145/90. Again, this is elevated and also concerning, especially in a pregnant woman at 39 weeks in active labor. And typically in pregnancy, the normal reading should be less than 122/80 mmHg. And even though labor can cause slight elevations due to the pain or maybe stress, this reading alone exceeds the threshold for concern. Now, the key context for this elevated blood pressure is that the client had a prior history of preeclampsia in their first pregnancy, which can also increase her risk of recurring preeclampsia by 15 to 25%. And so with this type of hypertension in pregnancy, whenever it will reach about 160 for the systolic and 110 for diastolic, it's going to be considered as severe preeclampsia. So this is a huge warning sign. Now, remember that preeclampsia has a risk here. It is really a risk at this time. Remember about the client's history, and this can also increase or it can put the client at risk for endothelial dysfunction. This can lead to proteinuria. There's going to be retention. That's why the client has 2+ edema. And do not forget that it can progress to eclampsia. The client will end up with seizures or the HELP syndrome. Remember about the hemolysis, elevated liver enzymes, low platelets? These can happen in eclampsia, which are both life-threatening for the mom and the baby. Now, in this context, wherein the mother is already in active labor, the hypertension can increase the risk of complications like abruptio placenta, wherein the placenta separates prematurely because of reduced placental perfusion. This is going to affect the oxygenation to the baby, or the maternal or the mother can end up with a stroke because of a possible elevation, another elevation of the blood pressure. And so the next step that you should be doing in this scenario is to recheck the client's blood pressure to confirm the elevation. You're going to assess for other symptoms of preeclampsia, such as headache, epigastric pain, visual disturbances, and also check for proteinuria using a urine dipstick test. And don't forget about the baby. You need to incorporate fetal monitoring to ensure the baby is not in distress. Now, the next manifestation that you should highlight is the pain that is reported 7 out of 10. So this is significant, especially when a woman is in active labor. And it says in the case that they are 5 centimeters dilated, right? 90% effaced, and the contractions occurring every 4 to 5 minutes. Even though pain is expected in labor, the 7 out of 10 pain level indicates that there is severe discomfort, and this could impact the mother's ability to cope and progress in the delivery. And so, why does this matter? Well, take note that severe pain can lead to maternal exhaustion, especially if the labor is prolonged. And it can also increase her heart rate, which is already elevated, and the blood pressure of 145/90 due to the stress response. And this can potentially exacerbate any underlying hypertensive issues. Now, this can also impact the fetus because with uncontrolled pain, this can cause hyperventilation, poor oxygenation, which will reduce the placental blood flow and will lead to fetal distress. And this can lead to release of the stress hormones, which are going to be released during severe pain, which will also decrease the blood flow to the uterus. Now, remember that the client is the spouse is overseas, so there is no spousal support around this time, even though her sister is taking care on the first child, but definitely she is alone. And this lack of support may also amplify her pain perception and anxiety. So this is going to make it harder for her to cope as well. Now, take note about the labor progress. At 5 centimeters, she is in active labor. But if the pain is not managed well, it could stall the progression by causing her to tense up during the contractions. This can lead to dysfunctional labor pattern. And what you should do here is to assess the pain further. Is it typical contraction pain, or is it something that could be a sign that there is hypertonic contractions? And so you gotta carefully assess this client further. Now, the immediate interventions might include non-pharmacologic methods. Maybe you're going to remind the client, if they have already done this in the past, about the breathing techniques, positioning, or maybe this client will require medications to decrease their pain sensation as well. Now, what other manifestation that you should highlight here? We have moderate or 2+ swelling in both legs and feet. The reason for that is because even though this is something that is expected in late pregnancy due to the increased fluid volume and the pressure from the gravid uterus, which can impede venous return, the 2+ edema takes several seconds to rebound, and this is much more significant. Now, the edema, especially at this stage, when it is associated with the high blood pressure and the client's prior history of preeclampsia, this is a classic sign of a hypertensive disorder, because alone, in the preeclampsia alone can cause endothelial damage. This can lead to leaky capillaries, and that's why this is going to be manifested as an edema to the lower extremities. And again, this can be associated with low protein in the blood, whereas there is a protein loss in the urine as well, which will exacerbate the swelling. Now, the edema 2+ also isn't not just normal during normal pregnancy, because this could also suggest pathological processes, especially in the context of the other findings that we have already encountered in the case. Now, this can also affect the fetus, because preeclampsia can also reduce the placental perfusion. It can lead to intrauterine growth restriction and also fetal distress. Now, the next manifestation that you should highlight here would be mother experienced the preeclampsia in the previous pregnancy. This is a red flag. This history of preeclampsia is a critical finding that requires follow-up. Again, this will increase her risk of recurrence at the present pregnancy by 15 to 25%. And again, the risk is higher if the previous preeclampsia was severe or early onset, though we don't have those details in this case. Now, at 39 weeks, she's still at risk because preeclampsia can develop late in pregnancy or even postpartum. Now, with this can also complicate with the active labor. This can lead to some complications such as abruptio placenta or maybe preterm delivery if severe, and it could probably lead to eclampsia or HELLP syndrome. And so in this case, you have to be hypervigilant in assessing or reevaluating the client's blood pressure and other manifestations such as headache or visual changes or maybe epigastric pain. And also make sure that you ensure the client's fetal well-being through continuous monitoring. Now, the other reported data here would be the primary language, which is Vietnamese. Okay, this is a very significant finding in the context of labor and delivery, because in labor, this requires frequent communication. The nurse needs to discuss pain management or labor progress, potential interventions if the preeclampsia worsens. Now, if the patient's English proficiency is limited, there is also a risk of misunderstanding, which could delay the care or it could lead to some medical errors. And remember that labor is a very dynamic, high-stakes situation where decisions must be made quickly. And so, for example, if her blood pressure spikes further and she develops severe preeclampsia, she might need an emergency C-section. And without clear communication, she may not fully understand the risks or the consent process, which could compromise her autonomy and safety. And she's already in a vulnerable situation. The spouse is deployed, sister is occupied with her child outside in the waiting area, and the language barrier could increase her anxiety. So it's going to make it harder for her to cope with the labor and potentially will worsen her pain or the blood pressure. And so the next step for the nurse to do here is to secure an interpreter immediately via maybe a phone or maybe in person to ensure the patient understands her care plan. And they can report symptoms accurately, such as maybe developing headache or maybe other manifestations such as abdominal pain. And so the other manifestations here are the contractions that occurs every 4 to 5 minutes, 5 centimeters dilated. These are manifestations that don't require attention. Where are you? Yeah, so these are basically normal part of the labor progression. And even though it's important to monitor labor progress, these findings alone doesn't require urgent intervention because these are normal part of the process. All right, let's move on into our next item here. We have a matrix multiple choice. So the case says a 35-year-old male patient arrived at the emergency department reporting chest pain and heart palpitations, and the nurse is now consulting with a physician about his treatment plan. His vital signs show a temperature of 98.7 degrees Fahrenheit, blood pressure at 96/44, heart rate of 122 beats per minute, respiratory rate of 22, and oxygen saturation at 92% on room air. Diagnosed with dehydration and hypokalemia due to gastroenteritis complications, he describes his pain as 9 out of 10. So your task for each potential healthcare provider order, decide if it's appropriate or inappropriate for the patient's current condition. So we have the potential healthcare provider orders. One is bismuth subsalicylate 2 tablets hourly as needed for loose stools. There's that potassium chloride 20 milliequivalents IV in 100 ml 0.9% saline via secondary line over 1 hour. Administer oxygen 2 liters per minute via nasal cannula, and normal saline 0.9% to infuse at 200 ml per hour, and furosemide 40 milligrams IV times 1. Now, so I want you to carefully analyze here if each of these provider orders is not appropriate or not appropriate. So what do you think about the first order here. Bismuth sabsalicylate 2 tablets hourly as needed for loose stools. The answer for this order is not appropriate. We know that this is a medication that is classified as anti-diarrheal, and this can reduce the intestinal motility, which is going to be a problem in a bacterial or viral gastroenteritis, because when you administer this medication, this can delay the elimination of the infectious organisms, and this can potentially worsen the client's condition. So, not appropriate. Now, look into the second order, which is potassium chloride 20 milliequivalents IV in 100 ml 0.9% saline via secondary line over 1 hour. The answer to this is not appropriate because the potassium chloride IV requires to be diluted to a maximum of 10 milliequivalents per 100 ml for safe IV use. And this order, it says 20 milliequivalents per 100 ml saline. This basically exceeds the limit, and this is going to put the client at risk for vein irritation, even cardiac complications. And also, take a look into the infusion rate of about over 1 hour. Imagine that. At a rate of over an hour, and this is a 20 milliequivalent, this is also surpassing the recommended 10 milliequivalents per hour infusion rate. So this is going to cause inadvertent hyperkalemia. So this is something that you should pay attention to. Do not administer potassium chloride exceeding 20 milliequivalents per hour, especially if we don't have any other supporting data that the client is placed in an ICU, or they are in continuous cardiac monitoring, or if they have a central line. The situation that we have currently doesn't have those information. And so we basically would want you to be really safe in the administration of this drug. So the maximum infusion rate should not exceed 10 milliequivalents per hour. So do not forget about that. So the answer is not appropriate. Now let's move on to administer oxygen 2 liters per minute via nasal cannula. Is this something that would be appropriate or inappropriate? Well, the answer to that is appropriate, because the administration of oxygen basically is going to help the client, especially that their saturation is a 92% on room air. This is way below the expected range. And when you are administering this 2 liters per minute of O2 via nasal cannula, this is going to help the client improve their oxygenation, and also to reduce respiratory strain, and also address some perfusion issue into this client. Now let's move on to the next one. Normal saline 0.9% to infuse at 200 ml per hour. This is also appropriate because in the case the dehydration has already caused the client hypotension. Take a look into the blood pressure of 96/44 and the compensating tachycardia of 122 beats per minute. And the IV fluid replacement at this current infusion rate of 200 ml per hour, this is going to help restore the fluid volume. It will stabilize the blood pressure. It will also support the perfusion, and definitely will address the client's issue in circulation and perfusion. Let's move on to the last order. Furosemide 40 milligrams IV times 1 now. This is not appropriate. Take a look into the patient's case again. The client has what? They have hypokalemia. All right, remember about that. Furosemide is a loop diuretic. This is going to promote much more of fluid and potassium loss, and this is contraindicated in a dehydrated, hypotensive patient, also contraindicated in hypokalemia. And then again, if you administer this medication, this could exacerbate the hypovolemia and could further worsen the hypokalemia, which will lead to cardiac complications. So definitely you're going to address the stabilization of the potassium first before you administer any potassium losing type of medication. So for this test item, I want you to carefully read the stem of the scenario to understand the patient's vital signs and the entire patient condition, and make sure that you highlight those critical information like dehydration, hypokalemia, gastroenteritis. And of course, this is expected that the client will lose a lot of potassium and other electrolytes in the lower GI tract. And also the client's blood pressure. Do not forget about that low blood pressure. The compensating heart rate of 122. They have been complaining of the chest pain and palpitations. These two are significant cardiovascular manifestations, and the pain, that is 9 out of 10. All right. So when you do the highlighting, when you really skim through the data, this will help you base your decisions on the patient's specific needs, not just assumptions. And make sure that you break down each order independently. You have to evaluate each order at one at a time, and make sure that you have to brainstorm to consider the purpose of the medication. Is this something that could harm the patient? Is this something that could benefit the patient? And don't let one order influence your judgment to another order. So you got to treat each order independently. And this is going to help you lessen your confusion in a matrix format where there are so many things that you have to decide on. So this is going to make your reasoning much more focused. Now, you also need to use your critical knowledge, recall the standard treatments and the contraindications for the diagnosis. So, such as the administration of the potassium chloride here. You got to recall the standards of the administration of this medication, right? Also, administration of furosemide in a case of hypokalemia. So think about the case itself and what the medication can do. Right? And you have to definitely eliminate those options that are pretty obvious that is already mismatching to the case. And so that ends our session for today. I want you to reflect on what you have learned. You tackle on those practice cases and keep honing your examination skills. And if you found this helpful, give it a like and subscribe for more NCLEX content. I want you to leave a comment, share how you fared with these questions, and we'll catch you on the next video. Thanks for watching.